Professor O'Byrne has been discussing the paradox of asthma. Professor, why is asthma a paradox?
The issue that I was addressing in my presentation is the paradox that we have extremely effective and very, very safe medications to treat asthma. These are inhaled medications, and for virtually all patients, they are containing inhaled corticosteroids, either as a monotherapy or in combination with long-acting beta agonists. So these drugs are safe, they're extremely effective, and yet the paradox is most asthmatics are poorly controlled. And this has been an observation that's been made now repeatedly over 15 or 20 years, and our ability to control asthma well hasn't really changed over this time period, while the medications, at least based on clinical trials, are so effective. The main reason for this is clearly that patients, while accepting the fact that they have asthma and may have symptoms, the symptoms are intermittent, and the patients are, in general, not terribly enthusiastic about using regular daily medications to treat intermittent symptoms. And so adherence to inhaled medications, particularly inhaled corticosteroids, is extremely poor in asthma.
And the delivery systems have been an area of intense development, as I understand it.
Yes, that's correct. We now have inhaled medications that are extremely easy to deliver, require very little manipulation by the patient, and which, as I said earlier, contain extremely effective medications. But unfortunately, even simpler delivery systems, or delivery systems that have ways of reminding the patient to use the medication, hasn't changed adherence very much.
So what can the medical profession do about the problem?
Well, the consequence of patients refusing or deciding or electing or forgetting to use their medications on a daily basis results in many patients relying on rescue inhaled medications, the most widely used of which are short-acting inhaled beta-2 agonists, drugs like Ventolin or terbutaline. And so characteristically what happens is that the patient takes an inhaled steroid, feels very well, feels normal, decides or forgets to take the inhaled steroid, and then over a week, 2, 3, 6, starts relying on the rescue medication. And importantly, the rescue medications that we have to use for asthma have no anti-inflammatory benefit to the patient, while the inhaled steroids clearly do. And so the patient then relies on a medication used intermittently, but which can actually not only not inhibit the inflammatory response in the airway, which is what's driving asthma, but in certain circumstances can actually enhance it. And there's now very good evidence that an over-reliance on reliever medications that contain short-acting beta agonists actually put patients at risk of exacerbations and, in extreme cases, even mortality from asthma.
Looking to the future, how positive are you about the situation being improved?
I'm very positive because there are now a number of studies, and I described 2 large studies recently published, which show that if the rescue medication contains a beta agonist, which you need in order to improve symptoms quickly, but at the same time contains an inhaled steroid, even though it's used intermittently as a rescue medication, the risk of very severe attacks of asthma are markedly reduced, and asthma control is improved when compared to using the rescue medication alone. And so this approach is now under consideration by a number of regulatory authorities around the world, and my expectation is that over the next few months, indeed, not in the quite near future, we'll be using reliever medications that have both a beta agonist, but also a steroid. And in that, if that's the case, then when patients do, as they do, rely on reliever medications, they are actually getting some of the benefits of an anti-inflammatory treatment approach.
And how well accepted are these new approaches by patients?
Patients love it. And it's because we're giving the patient control back. We're telling them, these are patients with mild asthma, I should emphasize, not patients with more difficult to manage disease, but the majority of asthmatic patients who have mild disease, we're telling them, you use your medications when you feel you need to use them. And the evidence is very compelling that if you do that with an inhaler that has both an inhaled steroid and a beta agonist, you get much better effects than if it's just the beta agonist alone.
So there's some good news coming for
I think
asthma
very
patients?
soon. Yes, exactly.
Thank you.